Thank you. Pleasure.
Thank you. Okay, the next, the third speaker is Dr. Wu Bo from the London School of Economics and Political Science. His speech is titled Adverse Experience in Childhood and Caregiving for Older Parents in Later Life, Building Capacity for Caring Society. Like the previous speakers, 20 minutes for presentation and 10 minutes for Q&A. Okay, please, Professor.
Yes, sure, no problem. Thank you. Let me just share my screen here. Okay. Can you see my shared slides? Let me just also swap. Can you see my shared slides in full screen, please?
Oh, we can see.
All right. Okay. Great. All right. First of all, hello everyone. I'm just truly honored to be invited again this year to give a talk in the global lecture series on Chinese economy. In this presentation, I'll be talking about the relationships between adverse experience in childhood and caregiving for older parents in later life from a caring society perspective. And the research findings.
Sorry, we cannot see the screen.
You cannot. Oh.
Cannot see your screen.
Okay. So I'm now sharing. Can you see the full screen or
no?
This is. Let me. Oh.
Okay.
Yeah. All right. Okay.
Oh, okay. It's okay. Thank you.
Yeah. I think I need to display settings. So is this the full screen? You can see on
okay,
here.
No problem.
All right. Okay. Great. So the research findings of this presentation are the results of team members. Other members of the team are Professor Xue Bai from the Hong Kong Polytechnic University and Peng Yunwang from the University of Oxford. We know that China is currently undergoing rapid population aging. At the moment, we have around 200 million older people aged 65 and over, which is projected to rise by 90% by 2040. Because of the rapid population aging, we expect that the number and the proportion of older people with the long-term care needs are expected to rise substantially in the next 2 decades. And here, long-term care needs refer to the need to receive assistance to perform activities of daily living. These are personal care tasks like eating, dressing, going to toilet, as well as instrumental activities of daily living. And these are domestic tasks like making phone calls, doing shopping, and doing laundry and cleaning the house. The overwhelming majority in the Chinese context, the overwhelming majority of the long-term care responsibilities are assumed by family members. These include one spouse of care people with care needs, and a second adult children of older people. We know from the official statistics that the middle-aged and older Chinese people aged 45 and 64 years old, and this is the main providers of unpaid care or informal care for older parents. And the population in this group is projected to decrease by 1.4% by 2040, which is in contrast to the rapid population aging. So it seems that inevitable we will be facing a looming care gap if we look at what is going to happen in the next 20 years. Faced with this challenge, I think there are two possible ways to address this. One is to focus on the demand side, that is to promote healthy aging, by helping people get health, by helping people get healthier, we can reduce the overall demand and the need for long-term care. And another approach is to focus on the supply side. What we put forward here is to build a capacity for caring society to boost the supply of informal care. by a caring society, here we mean social institutions and the environment where caregiving activities are highly valued by society, and the barriers to caregiving are greatly reduced so that caregivers can provide care for their loved ones in the family according to their own preferences, regardless of whether we are talking about creating a caring society or increase the supply of informal care. The first thing we need to do is to have a good understanding of the factors associated with informal caregiving, and that is what determines people's caregiving behavior. There are already useful theoretical frameworks in the literature. The first one is the informal care model, put forward by Bruce van Gruno and De Boer in 2016. They propose that informal caregiving is influenced by, first of all, the disposition of caregivers. This includes attitudes and actions of caregivers, social norms, how far caregivers live from their family members, whether they have time and the skills to provide high quality care, whether they can afford to give up employment to provide care. They also proposed contextual factors. These are community care, technology, family members, and social networks that can provide support for informal caregivers and to empower them or enable them to perform their caregiving responsibilities better. Another theoretical framework is resource theory of older age, and this proposed that informal caregiving is influenced by different types of resources possessed by an individual. These include the financial resources and the social capital, including income and education. There are also health resources. The argument is that people with better health have higher capacity to provide care. And finally, this theoretical framework talks about the caring resources, and this is not dissimilar to the contextual factors in the informal care model, because this relates to the access to support from other family members and the social networks for informal carers. When we look at these theoretical frameworks, we notice that there's one thing that is glaringly absent, which is a life course perspective. We have talked a lot about how personal resources can have an impact or influence people's caregiving decisions, caregiving behavior. In the meantime, we should also bear in mind that personal resources do not take formation in one day. Instead, they are the results of cumulative events and experience throughout the life course. And more importantly, this means that life outcomes in different life stages, they are intrinsically linked. I'm not going to go into the details of the theories, life course theories here for the sake of time. But let me just briefly summarize the empirical evidence in this area of research. What the existing research shows is that people experiencing childhood adversities are more likely to have poorer health, lower socioeconomic conditions, and a less positive attitude towards caregiving. And we know from the informal caregiving literature that these are also the factors that can lead to a reduction or decrease of informal care provision. So pulling these two strands of literature together, we have a hypothesis in mind. That is, we expect people with adverse experiences in childhood provide less care for older parents in later life. And if this hypothesis is supported by data, the implications are by addressing childhood adversities or reducing the prevalence of childhood adversities, we can boost the supply of informal care in the future. This potentially provides one way to address the issue of labor shortage. And by this, I mean shortage of informal caregivers because of the changes in population structure. To go about testing this hypothesis, we use 4 waves of data from the China Health and Retirement Longitudinal Study CHALS. We use the baseline survey to follow-up surveys and the life history survey. We focus on people aged 45 years old and over. And this point is very important. We focus on those people who have at least one living parent or parent-in-law, because people without surviving parents do not face demand for long-term care. So that is irrelevant to our analysis. We have two outcome variables we're interested in. The first one is whether or not a person provided care for their parents or parents-in-law. This is a binary variable. And for people who provided care, we look at the hours of care or the intensity of care. That is, whether provide less than 10 hours or more than 10 hours of care. Again, this is a binary variable. We use the 10 hours of care as a cutoff point because our previous research shows that when people provide more than 10 hours of care from family members, this starts to have a negative impact on their health and employment. We look at the 13 types of childhood adversities, including parental death, poor mental health of parents, poor physical health of parents, physical abuse, alcohol abuse, and witnessing domestic violence. We counted the number of childhood adversities because we think there might be a dose-response relationship between childhood adversities and caregiving. By using a count variable, we can look at the cumulative effects of childhood adversities. When looking at that relationships, we control for social demographic variables, health resources, and socioeconomic factors. Again, I need to stress that here we are controlling for the number of living parents because presumably people who have more living parents they are more likely to face a higher level of demand from their parents. So this needs to be controlled for. This table shows the results of bivariate analysis of childhood adversity in caregiving. If we look at people not providing any care for their parents, 34% had no childhood adversity, 17% had 3 or more childhood adversities. They on average have 1.3 adversities. If we compare this with people providing more than 10 hours of care, nearly 40% had no childhood adversities. 14% had 3 or more childhood adversities. On average, they have 1.15 childhood adversities. These differences are statistically significant. Then we conducted regression. This is multi-level logistic regression analysis so that we can include control variables to look at the relationships. We look at different models. In model 1, we did not include any control variables. The odds ratio of the logistic regression model is 0.92, meaning that an increase of one childhood adversity is associated with a decrease of 80% in the odds of providing care for their parents, which means that more childhood adversities can lead to lower probability of providing care for older parents. Then we include control variables one by one. We see that the odds ratio get closer to 1. But even if after we included all of the control variables, the odds ratio of the childhood adversity variable is still statistically significant, meaning that there's still direct impact on caregiving. What about the control variables? Because this has been already investigated in the international literature, so I'm going to very quickly talk you through this. What we found in the data is that people with more severe cognitive impairment are less likely to provide care. People with poor self-reported health are less likely to provide care for their older parents. And the people with more severe functional disability are less likely to provide care for their older parents. People with a higher level of income are more likely to provide care for their older parents, and people with a higher level of education are more likely to provide care for their older parents. We also look at, for people who provided care for their older parents, we also look at the hours of care or intensity of care. Again, this is multi-level logistic regression analysis. We look at different models. In model 1, we didn't include any control variables. The odds ratio is 0.93, meaning that an increase of one childhood adversity is associated with a decrease of 7% in odds of providing high intensity care. That is, experiencing more childhood adversities reduce the probability of providing high-intensity care. Then we included all kinds of control variables here. Still, the odds ratio of childhood adversity variable is still significant. Using this regression analysis, we can estimate the total number of caregivers for older parents, and by how much we can increase the number of caregivers if we reduce the number of childhood adversities. We estimate that in 2020, there were 58.3 million caregivers providing care for their older parents. Remember that these caregivers are aged 45 and over. If we reduce one childhood adversity for every person, we estimate that in 2022, there would have been 60.5 million caregivers. That is an increase of 2.2 million caregivers. So in an extreme scenario, if we can reduce the number of childhood adversities to 0, our estimate is that there would have been 2.6 million caregivers in 2020. That's an increase of 4.4 million in the number of caregivers. So let me just briefly summarize our research findings. Our analysis shows that people experiencing fewer childhood adversities have a higher propensity to provide care and provide more hours of care for their parents in later life. We also see that better health conditions and a higher socioeconomic status associated with a higher propensity to provide care. And finally, if no one had experienced any adversities in childhood, there would have been 4.4 million more caregivers for older parents in 2020. Admittedly, this is a hypothetical scenario, but does show that if we can address the childhood adversity issue, we can indeed boost the supply of informal care, and that this can take place in a non-trivial fashion. How do we interpret this result? First of all, we think it is important to build capacity for a healthy and competent caregiving labor force, given the strong correlation between health status and caregiving. So this goes back to the point that a healthy population is probably the most important asset of a country. And the second, we have seen an increasing number of studies in recent years reporting that childhood adversities have negative impacts on health and economic outcomes in later life. Our contribution in this study is that apart from those life outcomes, childhood adversities also have consequences for people's caregiving behaviors. At the policy level, to boost the supply or increase the provision of informal care, there are practices and policy measures across the country. And these measures and policies normally have targeted at adult caregivers. The labor market, for example, having a flexible working arrangement so that people can balance caregiving responsibilities and their employment better. And there are also policies that is focusing on the demographic structure, for example, by increasing fertility rates. Certainly, undoubtedly, these measures and the policies are very important. And the message we want to get across in this study is that social policy reforms and interventions do not necessarily have to confine to those measures. And we want to draw your attention to the environment where children grow up, because we think our analysis shows that a conducive environment can facilitate the development of a positive caring attitude, higher level of capacity and competence to provide care. So one of our central argument in this study is that education, family, and health policy that protect children from traumatic experience are quite relevant here, because they can help to build a caring society from the very beginning of human development. And those caring environment, caring attitude, and capacity can then pass down from one generation to another generation, and this can be supposedly can be a useful avenue to increase the supply of informal care and address the issue of population aging. So that is all my presentation today, and thank you for listening.
Thank you very much. And we have two questions in the chat box. Would you like to check it and answer?
Okay, right. So it seems future care seems like come from a kind of revenge. Is it possible that this lack of caregiving for it stem from? Right. Okay. First of all, the first question is about the negative correlation is from the between childhood adversity and caregiving is subjective. I think partly. There might be some elements of this, but I would not use the word subjective revenge. I don't think this is intentional. I don't think there might this. I think we think this related to a less positive caregiving attitude, but I don't think this is kind of revenge, because what we know from the literature is that childhood adversity leads to insecure attachment. That is how they perceive the social relationships. I do not think that is kind of revenge. It is just how they frame the social relationships should be. That is, when people have care needs, how people should respond to them. And this kind of revenge might not necessarily directly targeted at their parents. It's just how they perceive social relationships overall. I think that's only part of it. And if you see the other elements of why there's a negative relationships, one is health. We see that people with childhood adversities have poorer health, and because of poor health, and you could expect that their capability of providing care is lower. A person with poor health, you wouldn't expect a person with poor health to provide a lot of care compared to a person who is highly energetic and perfectly healthy. That's another issue. The second one, you talk about economic aspect of it. Yes, that is very true, because of one of the elements we see is that people with a higher level of education and a higher level of economic status, they are more likely to provide care for their older parents. And if you look at economic status, one of the reasons is that people with high economic status, they do not need to squeeze their time, and they do not need to just to get employed in several jobs to make ends meet, which means that there's little time left for them to provide care. That is, they have more resources to provide care for their older parents. So I do think that economic and physical health, or even cognitive health, because I've just shown that people's cognitive functioning is very important. People with cognitive impairment, they're less likely to provide care, because providing care is very cognitively taxing. It requires a lot of cognitive resources. So people with high level of cognitive impairment, their probability of providing care is greatly reduced. I hope that answers your question. The second question, as technology advances rapidly, how can digital solutions such as remote monitoring, artificial intelligence, virtual support be harnessed, particularly for those individuals who experience childhood maybe less client? Yes, I think this is a very good question. I think this is these are also the areas of research my colleagues and I have been conducting in other projects. Yes, and there will be great potential. And I think, especially as far as I know, governments in different countries have been highly interested in exploring the potential of using technology and to support informal caregivers. And if you remember, when I talk about the theoretical frameworks, of informal caregiving, and one of the elements that is mentioned is technology, because this can enable caregivers to perform their care tasks better. But there are caveats though. One thing is when you talk about remote monitoring, and then there's ethic dimension of it, what are the ethical implications of you having a device monitoring an older person 24/7. That is one. And another is you have artificial intelligence powered assistants. And one issue is the accessibility of the technology, whether it is easy to use. Again, linked to the point I talked about just now, providing care for older parents, providing care for especially older parents with a dementia requires a lot of cognitive resources, because you are managing care on behalf of another person. That is cognitively taxing. So if you have technology that requires even more cognitive resources, it won't be that helpful. So that relates to the design of your technology. Even though I agree that there will be huge potential to use technology in this aspect. And the third question is, given the findings that early life experiences play a significant role in shaping informal care, what specific policies and interventions do you recommend to foster a more caring culture from childhood onwards, particularly in the context of China's aging population? I think this links to the two dimensions. The first one is that we see there are direct impacts of childhood adversity on caregiving. So one solution, one important dimension of this is that those education policies that support children and protect them from exposure of adverse environment. And that there are different aspects of it. And I have looked at the different dimensions in the past in other studies. One example is bullying victimization, because we know that bullying victimization can have devastating impacts on the children's mental health, cognitive functioning, and then in later life, employment, education, so on and so forth. So you have a knock-on effect. So interventions focusing on protecting children from bullying victimization is apparently one of them. And other family policies, so that you have a functional family and harmonized family relationships, how to promote that. That is another dimension of it. And certainly another one is healthier population, because if children grow up in a family where parents are mentally, physically healthy, that is certainly greatly beneficial to the children.
Okay, the last question, number 4, please.
Then last, does your research imply that left behind children, due to their parents' migration, are less likely to provide care for their parents when they get old? Well, I think that's a good point. So to what extent that can have an impact on their parents, I think that depends on certain things. One thing I need to talk about is that I've tried to describe this in childhood adversity as some kind of very devastating force, but we should also remember that it just puts people in a disadvantaged position. People have resilience, people have agency, their own agency. That's people experiencing childhood adversities, they can bounce back. So it's not deterministic. In terms of left behind children, there is a possibility that it can have a negative impact on their health, on their secure attachment, on their attitudes towards caregiving. But I think more research would be needed to look at that, because there might be hypotheses to argue that left behind children will have a lower propensity to provide care for their parents. But again, we need to look at data. If we have got data, we need to look at data to test that hypothesis. Yeah,
Okay.
hopefully this is helpful.
Thank you very much. And because of time constraints, we have to close the first half of this session. Thanks again to the three speakers and all the audience for your support and cooperations.